So just to start, looking at some of the dimensions, I also think it's important just to put some numbers around what we're talking about here. We're just about under just under 5.5 million population in Scotland, and about half of that is of working age. Of course, working age is becoming more elastic as people are being expected to work longer. About 72, I think it's actually about 75% of folk are actually in some sort of paid employment now, so that's a big chunk of our population. We have 140,000 unemployed. We have a very persistent 250,000 people who are out of work because of health-related conditions, which we're very keen to support to get back into work in some way. And we also have about 1 in 6 people in the working age population suffer some sort of poor mental health issues. Just a wee reminder of what Scottish Government is and isn't responsible for. We have health, education, justice, that sort of things. It's quite difficult in the health and work area because there is a lot of overlap between the areas that are responsible for, the UK government's responsible for, and the areas that devolved powers in Scotland are responsible for. Things like employment law, occupational health and safety are reserved, but delivery of health care is a devolved issue. But we've got some new powers coming our way around taxation, some disability benefits, and some aspects of employability programmes. So that starts to get our ministers a bit more interested in what the working age population is actually doing, and the balance between tax revenues and the costs of benefits. So it's starting to slip up ministers' agendas a bit. Why do we think health and work is important? Well, it's important for the individual. It provides economic means. It gives them an income to live on. It gives people a social environment. It gets them out of the house in the morning. And it gives people a position in society, depending on the type of work they do. But there is importantly, a socio-economic gradient of health, which means that there are much poorer health outcomes for people who are in low-paid jobs, jobs that require low skills, people who have jobs where they have very little control over what they do, and they have a lot of high demand on them while they're doing their jobs. And these things affect people's health and well-being. Michael Marmot famously did a study of civil servants in Whitehall a few decades ago, which showed that the permanent secretaries and the people at the top of the pecking order there had the best health outcomes, and the folk right down at the bottom, the cleaners, the folk who sat at the reception desk, worked in the mailroom, had the worst health outcomes. And it tends to be that the more you can delegate to somebody else, the healthier you are. So it's quite good for your health and well-being. Just think about what that costs. It's been estimated that poor health in the workplace or work-related ill health costs the Scottish economy 10 billion a year. And that's a huge number. I mean, if we could just scratch the surface of that, that would make an awful lot of difference. And it's causes, the obvious ones: sickness, absence, lost productivity, cost of the benefits system, and looking after people's health and well-being as they get repaired and put back to work again. So prevention is very important. We want to make workplaces safe and healthy and promote well-being so that people aren't damaged or harmed in the workplace and they remain active and productive. And then if people do become ill, and it might not be work-related, but if people develop a health barrier to the work so that they go off sick, it might be short-term, it might be long-term, they need early intervention. The earlier the intervention, the better. So employers need to be able to recognise that they can offer support and to make that available. Occupational health needs to be available, and there's an interesting, if I remember, I'll come back to that point later on. And there should also be a planned return to work. So there needs to be an interaction and a discussion between the employer and the employee about how the health issue is a barrier and what can be done to help that person get back to work. So a wee bit of history there. We've been developing policies in government for quite a long time now, and it goes way back to 1996. We were trying to make Scotland a more attractive place for inward investment, that people were coming from the States and Japan looking to set up here and going, look at your shocking sickness absence levels, what are you going to do about it? So we started off with our safe and healthy working, and that's evolved over time into healthy working lives. And we've developed a number of other services, Fit for Work pilots, which came out of the work that Carol Black did in around about 2008. And then we had the Fit for Work service, which sadly is coming to an end because nobody used it. And I like to use this diagram just to illustrate, well, it illustrates my thinking at least, which is that people find themselves somewhere on this continuum at any point. We're all somewhere there. Most of us want to be up at that end, and we would like most people to be up at that far end there, keeping people safe, healthy in work. But people do fall out, and it's an important thing to bear in mind that the further people are down towards this end, the more expensive it is to keep people there. So if you're out of work, incapacitated, you're on benefits, which is a cost to the taxpayer, but also to bring people back up to the other end costs a lot more in terms of support and intervention. So we need to get the interventions in as early as possible and move people as far to that end of the continuum as possible. To that end, we've got no end of policies and strategies, more than you could shake a stick at, and there's been more since I produced that diagram. But just a few that I'd like to focus on there. We had a Healthier Working Lives, which is probably a very key strategy back in 2004 when we established the Centre for Healthy Working Lives. There's been numerous reviews of various aspects of health and work since. I think the key ones probably at the moment are the two at the bottom there, the Stevenson Farmer review of mental health and employers, which I was quite surprised at that. It asks an awful lot of employers in terms of supporting mental health of employees in the workplace. I'm still not quite sure what that's going to look like in practice. We're still having discussions with the UK government on that, as we are on the Improving Lives, which is about supporting people back, and that's where they've taken the decision to pull the plug on the Fit for Work service. And there's an awful lot of discussion in that document about the future of occupational health, who's responsible for delivering occupational health services for employees. I'm going down to Wales next week to meet with the UK government and Welsh colleagues to discuss how that document and the proposals in it get taken forward. So it's a bit vague at the moment. It's not clear what the UK government's talking about in there in terms of what's relevant to Scotland and what's only relevant to England or England and Wales. It's all a bit opaque at the moment, and I'm hoping to get a little bit of transparency there. I'd just like to set a bit of context for the health and work policies that I'm responsible for. It doesn't sit in splendid isolation. It sits alongside other parts of Scottish Government's policies, and most notably are the Scottish Business Pledge and the Fair Workers. I don't know if any of you organisations have signed up to the Business Pledge, but it's about encouraging a positive work experience for people, so introducing a living wage, making sure there's investment in the young workforce. And fair work is about identifying the dimensions of fair work so that people feel that work is a place that's worth going to, worth turning up, worth doing a good job and going home safely at the end of the day. So if we look at the sort of things that we've done up to now, I mentioned Healthy Working Lives, and that's been running since 2005. It's about providing advice principally aimed at employers. We have a confidential advice line. We have an advisor network based in our territorial health boards. We've got a nice, it's actually a shiny new website, just went live a month or two ago. There's a Healthy Working Lives award programme, so people, if they tick all the right boxes, can get a nice plaque to stick up in the reception of their head office if they want to do that. Healthy Working Lives has been given a remit to focus on the SME sector, and particularly we know that that's where there's less support. If you're working for a very small organisation, you tend not to have HR functions, occupational health, health and safety. It's usually the guy who owns the business and runs it. So there's a focus on getting the messages that support, advice, tools are available through Healthy Working Lives for the SME sector. We've been developing return to work support for people who do become ill or injured, and that creates a barrier to them remaining in work. So we've tested rehabilitation pilots in 3 sites. That's evolved into a Scotland-wide pilot with some DWP support about 8-9 years ago, which is called Working Health Services. That in turn provided a model for UK Government's Fit for Work Scotland, which terminates at the end of May at the Fit for Work Scotland. He says, we're no longer taking referrals into it. The advice service remains. I don't know if anybody's actually any experience of Fit for Work, but we found folk just weren't referring in, which is a bit of a disappointment. But we'll learn our lesson from that. GP sick note was replaced by a fit note about 2010, 2011. There are still some ongoing issues about how good GPs are at using that, and part of the discussion with UK government is about how we can help GPs use it better, use it more effectively in order to provide advice to employers and what they can do to support employees getting back to work. And our allied health professions strategy has included a very important focus on work so that our AHPs recognise that they need to have the skills and the knowledge to ask questions about work when they're working with patients, so they can understand whether or not the condition is a barrier to work, and then offering the right advice to help people to have the conversations with their employers about getting back to work. I'll just briefly touch on working health services, because it's one of our better services that we're really proud about this. It's been evaluated, it comes out really well, very positive in terms of the rates of return to work, of the patient experience and the employer experience. It's very cost effective because it's telephone based, there's very little face to face, and it uses importantly the biopsychosocial approach. So it's looking at all the issues in an individual's life that might be impacting on the health. So if somebody's presenting with back pain and that's causing them to go off sick, it might actually be because they've got some serious other issues. They might have money worries, they might have relationship issues, all kinds of things. So the approach with the case manager is to really unpick all of that and find out what are all the issues in a person's life. And if they have other things outside of the health condition that's a barrier, they're referred into services that can support them to address these. So some of the new things. We're developing what we call a single gateway pilot. We found in market research that people get a bit confused because we've got healthy working lives, we have working health services, we had Fit for Work. People didn't know what the differences were, who could be referred into who was eligible. So what we're going to test, kicking off in July in Fife and Dundee, is what we're calling a single gateway, where people will just have one phone number or go to one website, and that will get them access to the relevant service once they've gone there. So they don't have to go, which service should I be contacting? They'll be able to just pick up the phone. So a GP will be able to contact it or encourage a patient to refer, or an employer will be able to refer a patient into the service, and then we'll have someone who will work out which is the best service for them to get behind that. So just testing, trying to make it as simple as possible for people to use. Linked to that is a bit of stuff called predictive analytics, where we're going to collect data on the people who go through the services, so that we can see if we can actually work out what's causing people to present into the services, and see if we're able to work out some factors that would predict earlier when people are at risk, so that we can get interventions much sooner and get upstream, catch people earlier before conditions have become too acute or even become chronic. So we want to catch them early, get them into the right treatment and support, and back to work quickly. So that's going to run alongside the single gateway pilot. An interesting new development is that UK government announced just last month that for the purposes of statutory sick pay, they're prepared to accept an allied health professions advisory fitness for work report. This is something that we've been piloting in Scotland, in Fife and in Grampian, along with other parts of the UK, that up to now these fit notes, as effectively they're fit notes, because they're issued by an AHP, not a GP, tend not to be recognised for official purposes, but UK government says they will, for purposes of benefit. So what we want to do now is roll this out and encourage employers to recognise this, that they don't need to get a note from the GP if they can get one from an allied health professional. But AHPs are much better placed to understand the conditions that people are presenting with and the impacts on their ability to work and what they need to do to get back to work. So we're going to be working on that over the next while. And linked to that is the Active and Independent Living Improvement Programme, which again is part of our allied health professional strategy. There's a real focus on vocational rehab here and getting the AHPs properly skilled to ask the questions and support people, recognise the importance of getting back to work. So how am I doing for time? I'll rattle through the last few slides here because I've gone to the trouble of making them, so you're going to get them. There's a few challenges coming up. An important one is the ageing population. That's a population, well, we're going to say a pyramid. It's not so much a pyramid, more a mushroom cloud. 2041 is what the population will look like. We've got a real challenge there that there's not an awful lot of young folk coming through to come into the workplace. I think 2041, the workplace is going to look very different from what it is today. But there's an awful lot of old folk there, and I'm up there near the top somewhere, needing looked after, needing people to pay their taxes, to provide for my care, or my carers. But there are challenges there. There are challenges for us all in terms of what do we do with our workforce. So, more and more people in the workforce are going to be over 50. They're going to have to work longer before they qualify for their state pension. Most people over 50 tend to have at least one long-term limiting health condition. I know my hip's telling me I do. And there are also some particular, I saw some analysis recently that said some particular industries are facing serious recruitment issues over the next 10 to 20 years in terms of the current workforce retiring and having issues in being able to recruit. I think teaching in particular is one that sticks in my mind from that report. So what we need to do is develop the tools and the advice for age-inclusive planning. So really this is going to be aimed at employers. What do you need to do to think about analysing your workforce, knowing when people are going to start thinking about retiring? How are you going to try and retain the skills, the knowledge, get that passed on to next generations in a way that helps to support people to remain in work for as long as they want to? And an awful lot of folk are going to have to work for an awful lot longer than they were originally planning, I think. Mental health is another challenging area. We've launched our 10-year mental health strategy last year. It is a growing issue. It seems to be, I'm not sure it's all work-related. I think some of it's just the stresses of modern life generally. Folk find it hard to cope with that. We do have a range of services already available. We'll have Scottish mental health first aid training, Healthy Working Lives delivers training to employers around mentally healthy workplaces, and we're looking to develop that and make more of that available as we recognise that that's a really important challenge. I'll just come to my last slide now, or second last slide, but I just came across this one recently. Our AHPs are doing some work around the life curve. What they're trying to do is identify when people need support from AHPs, because they reckon that people are bumping up against the health services too late in terms of the development of their condition, and they would like to get some analysis that says, can we get, again, it's about getting upstream, getting earlier. The two lines there, the top line is the ideal, this is basically you're born and it's all downhill after that. But it's which route you take. So, you can decline gracefully and gently to your end of your days and enjoy your last years in a relatively healthy retirement if you're lucky enough to have a pension. The bottom one is you don't even live long enough to get to your pension because you're falling apart and you've declined. So what we're trying to do, what we want to do is move more people up towards the top as far as possible and understand what happens in people's lives. So this is an ongoing piece of research. I think it will be quite interesting when it comes to its conclusions in terms of the working age population. This is looking wider than the working age population because it's looking about the care needs of people in their later years, which is where a lot of the demand in healthcare services is. But I think we all want to be up there.